Everybody, and welcome to today's webinar on advanced therapies for Parkinson's disease by Dr. Devin Hall. We are so pleased to have her. I just wanted to give a shout out quickly to one of our sponsors who has been helping us with this year's webinars, and that's AbbVie. So thank you to AbbVie for always supporting us and being available to provide education to those living with Parkinson's, because I know that's a passion of theirs. And on to the main event, I'd like to introduce Dr. Devin Hall, who's an associate professor in the Department of Medicine at McMaster University and movement disorder neurologist at the Hamilton General Hospital. She completed her neurology residency training at Western University in London, followed by a movement disorder fellowship at Columbia University in New York. Her practice includes the evaluation and management of movement disorders, including Parkinson's disease, and other Parkinsonian disorders, tremor, ataxia, myoclonus, dystonia, chorea, and as well as the education of medical learners. Today's webinar, she's going to be just giving a review of deep brain stimulation surgery and levodopa and carbidopa intestinal gel infusions and the other treatments for advanced Parkinson's disease. So welcome, Dr. Hall, and thank you so much for being with us today, and I'll let you take it away.
Good afternoon, everyone. As has been stated, I will be discussing today advanced therapies for Parkinson's disease. And so just a quick review, I think as most people in the audience know, the key features of early Parkinson's disease include bradykinesia, which is reduced speed of voluntary movement and decreased spontaneous movements, including less frequent blinking, less facial expression, giving the face a mask-like appearance, slower speed of walking, and reduced arm swing while walking. There's also rigidity, which is muscle stiffness that makes it difficult to move. For example, makes it more difficult to get out of a chair or turn over in bed. And then finally, a resting tremor, which is a rhythmic, involuntary shaking movement that occurs when the body part is relaxed and disappears during voluntary movement. People with Parkinson's disease experience these symptoms to various degrees and in various combinations. As Parkinson's disease progresses, additional features will develop. These include motor symptoms like balance impairment, falls, fluctuations, and freezing of gait, swallowing difficulties and drooling, autonomic dysfunction, which are things like urinary incontinence, as well as orthostatic hypotension, which is where there is a drop in the blood pressure when a person changes positions, for example, going from sitting to standing, and this can result in someone feeling dizzy or faint. There are also neuropsychiatric features that can develop, including hallucinations and psychosis. And in addition, there can be cognitive impairment as well as dementia. So motor fluctuations are the target for the advanced therapies that I will be focusing on today. So what are motor fluctuations? Well, they include things like wearing off, delayed on, dose failures, and dyskinesias. As Parkinson's disease advances, the response to levodopa, which is the gold standard treatment for Parkinson's disease, changes from significant, predictable, and long-lasting early in the disease course to erratic and or brief later in the disease. Wearing off is where the duration of the effects of the medication becomes shorter and do not last until the next scheduled dose, resulting in the return of symptoms in between doses. A delayed on is where the medication takes longer to start having an effect or kicking in. And dose failures means that the dose never seems to start working. And these two fluctuations usually indicate erratic absorption of the medication. And then the third type of motor fluctuation are dyskinesias. And these are involuntary, uncontrolled movements, including chorea, which are these dance-like movements, and dystonia, which are cramping of the muscles that cause twisting or sustained postures. The most common form of dyskinesias are what we call peak dose dyskinesias. And these occur in the on phase, which is where the medication is working. And that's shown in the graphic here on the bottom of the page in the green section. There are also other types of dyskinesias that occur in the transition between the on and off phase. These are known as biphasic or diphasic dyskinesias, as well as dyskinesias that occur during the off periods, which are aptly named off-period dyskinesias. The therapeutic window, which is shown here in the screen in the sort of pink or tan color, is the amount of medication in the system that is enough to improve the symptoms of Parkinson's disease. In other words, to turn an individual from the off state to the on state, but not so high as to cause peak dose dyskinesias. As Parkinson's disease advances, the therapeutic window narrows, making it increasingly difficult to maintain a level that will control the symptoms of Parkinson's disease without causing dyskinesias. For wearing off, the standard treatments include taking levodopa more frequently. So, for example, changing from a 3 times a day dosing to 4 times a day. We can also add in or change to controlled release levodopa-carbidopa formulation. We can add a dopamine agonist, and these include things like pramipexole, ropinirole, or rotigotine. Adding in a catechol-O-methyltransferase or COMT inhibitor, and this is entacapone, or adding in a monoamine oxidase B or MAOB inhibitor, and these include things like rasagiline, selegiline, and a new medication called safinamide. All of these medications help reduce the off time. So adding in something like a dopamine agonist can reduce the off time by up to an hour and a half to 2 hours a day. Adding in a COMT or MAOB inhibitor can reduce the off time by 1 to 1.5 hours per day. The standard treatment for peak dose dyskinesias include reducing the dose of levodopa, stopping a COMT or MAOB inhibitor, or adding in amantadine. When these strategies are insufficient to manage fluctuations, then advanced therapies are considered. These include apomorphine, levodopa-carbidopa intestinal gel, and deep brain stimulation. And these are the current advanced therapies approved by Health Canada for the treatment of Parkinson's disease. And I've listed them here on the slide from the least to most invasive. Because of the invasiveness of these treatments, they are reserved for individuals that are having motor fluctuations despite the optimization of standard therapies. So starting with apomorphine. Apomorphine is an add-on treatment that is used as needed for the treatment of sudden off episodes, both predictable and unpredictable, or for unpredictable on-off episodes. To get approved for apomorphine through the Exceptional Access Program here in Ontario, a person would need to be receiving optimal Parkinson's disease treatment with levodopa and a dopamine agonist. If they are unable to tolerate a dopamine agonist, then they would need to have had a trial of a COMT or MAOB inhibitor. A person would be precluded from using apomorphine if they are allergic to the medication, if they are using a 5-HT medication, and this includes certain anti-nausea medications like ondansetron, as it can cause significant hypotension, so very low blood pressure, and severe liver or kidney disease. So apomorphine is in the family of dopamine agonists, and this includes other medications like pramipexole, ropinirole, and rotigotine. But unlike these medications, apomorphine is a self-administered or caregiver-administered injection that is under the skin, and it is used as needed. It is very fast-acting, so it kicks in within 5 to 10 minutes and usually lasts for approximately 45 minutes to an hour. It can be injected in the upper arm, in the thigh, or the abdomen, and usually it's advised that the sites get rotated. And some of you might have read about an apomorphine infusion, which is the same medication that is given via a pump just underneath the skin, but this isn't available yet in Canada. So to have this medication started, it requires a special visit to a movement disorder clinic in order to ensure that the medication is tolerated and to determine what the correct dose is. So about 1 to 3 days before this special appointment, an anti-nausea medication, in this case usually domperidone, is started. We have the person hold or stop their Parkinson's medication overnight or 12 hours before the appointment so that they come in the off state. Symptoms of Parkinson's disease as well as the blood pressure will be monitored at multiple points during the appointment, as well as doing a screening ECG and blood work. And so what will happen is every hour to hour and a half, an individual will receive an injection of apomorphine at a gradually increasing dose to find the right dose that turns the patient from an off state to an on state. So in terms of adverse or side effects from apomorphine, nausea and vomiting are very common, and that's why this anti-nausea medication is recommended to be started prior to starting the medication. There can also be injection site reactions, and this includes things like redness, bruising, or nodules, or a lump that develops at the site where the injection is given. There can be dizziness from low blood pressure, leg swelling, drowsiness or sleep attacks, impulse control disorders. So these include things like compulsive gambling, increased interest in sex, excessive shopping, and then finally hallucinations. Moving on to levodopa-carbidopa intestinal gel. So this is used for motor fluctuations, primarily wearing off, although it can also be helpful at reducing dyskinesias. It is specifically approved for individuals who respond to levodopa, but despite optimized therapy, again with levodopa, a COMT inhibitor, an MAOB inhibitor, and dopamine agonist trials, still spend at least a quarter of their waking day in the off state. A person cannot receive the intestinal gel if there is a disease of the stomach, intestine, or pancreas that would prevent the placement of a tube, such as gastric ulcers or a obstruction in the intestine. If there is an allergy to the components of the medication, if there's any untreated heart, liver, lung, kidney, blood, or hormonal disease, or if there has been a stroke within the last 6 months. So this is the same levodopa-carbidopa that is in pill that we usually give in pill form, but this is a unique formulation that is administered as a gel directly into the small intestine. It is comprised of a pump and tube system that allows for the continuous delivery of medication and provides a more constant and fine-tuned amount of medication throughout the day. Typically, it gets disconnected at night, although sometimes a physician will recommend that it is continued throughout the night as well. So before initiating this therapy, a percutaneous endoscopic gastrostomy jejunal or PEG-J tube must be inserted. This is a surgical procedure that is typically performed by a gastroenterologist. Essentially, what happens is a small incision is made in the skin and in the stomach wall to create an opening for the tube, which is then inserted and guided through the stomach and down into the jejunum, which is the first part of the intestine, just beyond the stomach. And this is where levodopa gets absorbed. About a week or so later, the individual will come in for a programming appointment, again in the off state, so having held their medication overnight or for 12 hours. Based on how much medication is being taken during the day, their movement disorder specialist will have calculated the amount of gel to be delivered regularly, as well as a specific morning dose and extra doses that can be used as a sort of boost to the medication. And this is done to replace essentially the oral medications. So the doses are individualized and may need to be adjusted over time. And so in this photo on the screen, you can see that there are numbers. So number 1 is the actual pump, and that controls the delivery of medication. Number 2 is the cassette, and that contains the levodopa carbidopa gel. It is connected through the connector, which is number 3, to the PEG-J tube, which is number 4. And then number 5 is the retention plate, which is the triangle shape that you see there, and that's really just to keep the tube in place. And the stoma, which is a small opening from the skin into the stomach. So in terms of adverse effects, these can be subdivided into those that are related to the medication and those that are related to the tube itself or the procedure. So in terms of the medication, these are the typical side effects that we would expect with levodopa, or that we could expect from levodopa carbidopa. So again, nausea and vomiting, constipation, dizziness from low blood pressure, dyskinesia, so those extra involuntary movements, hallucinations, as well as neuropathy, which is damage to the nerves, often in the hands and the feet, which someone will experience as numbness, tingling, or a cold or burning sensation. In terms of the adverse effects related to the procedure, these include things such as abdominal pain, redness, swelling, infection around the site where the tube goes into the stomach, or leaking from that hole where the tube goes into the stomach. And lastly, deep brain stimulation. So deep brain stimulation is used to treat motor fluctuations, both medication responsive off symptoms as well as treatment-induced dyskinesias. It can also be used to treat tremor that is inadequately controlled by medication. In order to qualify for deep brain stimulation, you need to have had Parkinson's disease for at least 4 years. And that we usually say 4 years because we want to ensure that a person actually has Parkinson's disease and doesn't have one of the Parkinson's disease mimics, who probably would not respond to deep brain stimulation. In addition, there would need to be motor fluctuations despite optimal medication with levodopa, dopamine agonists, amantadine, COMT inhibitors, MAOB inhibitors. And we would need to see that the symptoms do respond to levodopa. Deep brain stimulation should not be used in individuals with dementia who have uncontrolled heart, lung, liver, kidney, blood, or hormonal disease, or who have significant psychiatric disorders. So deep brain stimulation is thought to regulate abnormal patterns of electrical signals within the brain by interrupting these signals. And how it does this is that electrodes are inserted into specific regions of the brain, and it can be done either on one side or both sides, depending if we're trying to control only one side of symptoms or if there are symptoms on both sides. And the targets for these electrodes include the subthalamic nucleus, or STN, the globus pallidus interna, GPI, and for tremor, the ventral intermediate nucleus of the thalamus, or VIM. The second component of the deep brain stimulator is the stimulator itself, or the battery, which is inserted into the chest, sort of like a pacemaker. So before the surgery is even considered, an on-off examination has to be performed in order to ensure that there's an actual response to the medication. So we would want to see that the symptoms get at least 30% better. In addition, neuropsychological testing is done in order to rule out dementia or significant psychological disorders, which would preclude a person from getting surgery. An MRI is also done in order to help with the planning for surgery to determine the best path for the electrodes and make sure that there, again, isn't any other abnormalities within the brain itself that might prevent the deep brain stimulator from being inserted. So next, in the operating room, it is a two-part procedure. So the first part is where the electrodes are placed. So the skin is cut and holes are drilled into the skull. In order to actually put in the electrodes, some centers do this having the person awake. And so essentially what happens is there is a very small recording wire that is inserted into the brain to record activity of the brain and help determine the right location for the electrodes. A person will be asked specific questions and to perform specific tasks in order to help with the placement of the electrodes. Stimulation can also be applied to see if the symptoms that we're trying to treat actually respond. Other centers do this procedure asleep and rely on the imaging from the MRI alone in order to place the electrodes. And there are advantages and disadvantages to each of these different techniques. The second part, either done the same day or at a later date, is the insertion of the battery or the stimulator. Again, this is inserted into the chest. And essentially what happens is that the wires from the electrodes are tunneled underneath the skin, down through the neck into the chest to connect to this battery. Most will stay overnight and be discharged the next day after the electrodes are inserted. A few weeks after the operation, a movement disorder specialist will turn on the stimulator and will start adjusting the electrical signal. And so I don't know if you can sort of see, it's probably pretty small, but on the bottom right-hand corner of the screen, that is sort of the device. You'll see that there are sort of these two wires, and there are these little black dots on the wires, and those are 4 different contact points. And so the specialist can choose which of those contacts that they are stimulating at. They can choose how much, at what frequency, and these are how we're able to individualize and try to treat the symptoms of Parkinson's disease using the stimulator. Because this comes up a lot, I also wanted to cover what deep brain stimulation is helpful or useful in treating. So deep brain stimulation is useful, like medication, at treating the stiffness, slowness, and tremor, particularly in the arms and the legs. It doesn't work as well for, or may not work at all for, imbalance, freezing of gait, and the non-motor symptoms. Importantly, deep brain stimulation surgery does not improve symptoms more than the medication itself. And finally, medication reduction is not the goal of the surgery. Some are able to come down on the amount of medication that they are taking, while others are not. In terms of adverse effects, again, these can be broken down into surgery-related or stimulation-related side effects. In the former, We see things like infection. There can be electrode migration or misplacement. So the electrodes can sometimes move or not go into the right part of the brain. The electrode can break. There can be bleeding, skin breakdown around where the battery or the wires are inserted, and even death. In terms of stimulation-related adverse effects, these include things like difficulty opening the eyelids, which we call apraxia, slurred speech, gait disturbance, balance impairment, weight gain, and cognitive impairment or a decline in verbal fluency. And this is really why patients with dementia are excluded from receiving deep brain stimulation surgery, is that they do not want to make their cognitive impairment worse. And so, although the risks of surgery are actually quite low, they obviously can be quite severe. And so this is not something that we let just anyone get because of these severe complications. We really want to make sure that we're choosing the right patients who will respond from the surgery so that we are not needlessly putting them at risk for all of these potential side effects. So there are other advanced therapies that are still under development. So these include things like focused ultrasound, which is being used to treat motor fluctuations and tremor in Parkinson's disease, at least on an experimental basis. Many consider focused ultrasound as less invasive than deep brain stimulation surgery in that there is no cutting or drilling that is required, and there's no insertion of wires into the brain, but it's still a procedure that affects the brain. So it targets the same areas as the deep brain stimulation, but instead of inserting the electrodes to deliver these electrical pulses to interrupt the abnormal signal, it actually uses sound waves to burn or to kill these brain cells. And so in the case of focused ultrasound, the results are permanent, they're irreversible, and not adjustable. Whereas in deep brain stimulation surgery, there can be some reversal and there can be adjustments made. And another area of research are the spinal cord stimulators. And these are similar to the deep brain stimulator in that there is an electrode or a lead, but instead of in the brain, this gets placed onto the spinal cord itself, sort of at the mid-back level. And then there is a pacemaker or this battery that is inserted. And this, at least the preliminary results, has been shown to be helpful for individuals who are having freezing of gait because of their Parkinson's disease. And so that was a quick whirlwind through some of the advanced therapies. I'm happy to take any questions.